Thank you for being here, and it's our pleasure to introduce Dr. Reid Nichols.
If I fall, it will be a problem. Well, hopefully I can keep you guys all awake after lunch. I can only show you the most cute patients ever. I'm really fortunate to be here. Thank you for inviting me. My talk is called Watching, Waiting, and Working to Get the Best Outcomes. So I have a couple of disclosures. I do some consultant work for some companies. It has nothing to do with this, thank goodness. I won't be discussing off-label uses, and the families have given me permission to use their Gait Lab videos and pictures in my talk. So despite the title of my talk, I am a surgeon and I do like to do surgeries, but I'm going to tell you that's not the only way to do things. All right, Mary, who's that? So this is Mary. I want you to make sure that you notice that there's no road under her feet. There's air there. So this is very exciting. And for me, this is the kind of reason why I do my job, is to get text messages like this. So my objectives are to define the goals of treatment of arthrogryposis from neonate to adult. I can't hit every topic, I promise, and address the following questions. When to operate or not, when to wait, why to wait, and how long do we wait? So orthopedic surgery. The definition of orthopedic, the word comes from the Greek orthos, meaning straight and correct, and pedia, meaning rearing of children. Well, these are my children. These are neither straight nor correct children, I can guarantee you. So when I was thinking about this talk, this actually took me a long time to make because I'm really overwhelmed by the emotion that I feel when I take care of my patients. And I was first going to start and do this talk discussing what we do, because there's a we in this, not an I. But instead, I want to talk about what you do. So you do presentations and meetings like this. When I checked in last night, I got a huge hug from one of my patient's fathers, and then I almost tripped over a kid who was rolling around on the floor with his long leg casts on. And I think that you can't go to another meeting like that. You know, my limb deformity meetings are pretty cool, but not this cool. So in this kind of conversation, my fellow physical therapist and I had a kind of a eureka. And we realized how motivated we were by the patients we took care of. So we started this new hashtag, Nemours, AMC Watch Me. And let me just tell you, for history's sake, that I have never used a hashtag in my entire life until this moment. So I want to share a few things from you that give me kind of the oomph to what I do and the desire to look to see what else we can do. So here's one of my friends. You know, he's an avid baseball player. Doesn't matter if he has casts or a walker or anything, and he has probably one of the best cheering squads around. You know, she doesn't look so happy. I think there was a bad call made when she was watching Big Bird, and on the sideline of this basketball game, I think there might have been a bad call there because she does not look pleased. So this little guy, he was told by his pediatrician that he would probably never walk. Never say never. And actually, I have a bracelet on that he gave me, and it says never give up on it. So super powerful to me to watch this guy go crazy. And here's Miss Sassy Pants. It says have courage and be kind. Well, those are two great words for me, and there's nothing but courage in her. Oh, she's pretty normal as a child. You know, legs are going maybe the wrong way. So this family persevered, and she has done pretty much everything. She's met every obstacle with a cute little smile on her face, maybe a little sass too, but we love her dearly. And this little guy has turned into a big guy. He's now a senior in high school. He's doing pretty awesome stuff out on that ice. And she shares a passion that I share, and that's riding horses. You can do everything you want to do if you put your mind to it. And I wish I had the technologic capacity to have put a YouTube video up here about my friend Gayla, who's an avid tennis player and is a rock star. So here's Ben. He is doing something that I'm not that good at, and he's masterminding it with legs that don't bend very much. Here he goes. And then on the next video, he has 10 brothers and sisters that he has to keep up with. So this guy wouldn't let me do anything on him forever because it would mess up his soccer season. And So what he just said is, I'm on top of the world. So I think that's your testament. So even this little guy who's 4 years old can tell you how happy he is with what he's accomplished so far. So that gives me my motivation for my talk. There you go. It's all done now. You guys have done it for me. But I do get to take a little credit. I want you to notice that Nate did not score on me. And I made it to the local news this same day when I scored on him. I am very competitive. And I was very embarrassed, and I was a little remorseful that I had made such a big deal about the fact that I scored on him, that when he came back to clinic the next week, I apologized, and he simply said, Dr. Nichols, I let you score. So my motto in life is this quote, and my motto for taking care of AMC patients is this quote: passion gets you started, hope keeps you going, persistence gets it done. And I think we have to remind ourselves that the persistence, it's tough. Some days are not as good as others, but a lot of days are awesome. There's a lot on our plate, not just my plate or your plate, on our plate. There are a lot of things that AMC can affect, and so we have to take care of all of these sort of in unison. Some things will take priority over others at certain times of our life, and we just have to accept that. So we work with a team to maximize the best outcome, and I'm really fortunate at No More's that I have an awesome team. And I have met many of patients that don't have the same cast of characters, but maybe only have a few people around, or they have to travel a really far way. And I hope that we can encourage a lot of discussion with even the local doctors to be a part of our team. But it takes a village for sure. So life is not a 50-yard dash. You need to pace yourself for this marathon. There are no easy fixes, and there's not always the best timing for things. You know, maybe the day that baby came in, it wasn't the right day for casting. Or maybe this day, it wasn't the right day for surgery, so he got a cast instead of surgery. But man, he's doing great things now, which is really good to see. So the basics build the future. We need to teach kids to eat, to sit, to stand. Not all will accomplish that, but we were going to try to give them the best option for getting there. So can we predict the future? Can we categorize each patient to be in one section so we can say, hey, I think if you have this, this, and this, you will accomplish this? I would say that we've even noticed in some of our research that we can push people to a higher level with therapy and just good luck sometimes. But we may be able to predict the future, but the future may be actually below this level and in the genes. So we know, most of the people in this room know what the typical involvement in arthropoiesis is. It's from head to toe, and it can affect everybody a little differently. If you guys look around this group of people here, we know that if I look at my neighbor, one person does not look like the next person, and that makes my job a little bit more complicated. There's so much variety. All right, so I'm mostly a lower extremity surgeon. And so I'm going to kind of skew my talk a little bit to that. I know Dr. Van Boss is going to talk about the spine, which is great, and Dr. Feldman is going to talk about the hip and knee a little bit more in detail than I will. So I'll concentrate on the whole picture and a little bit more on the feet. Again, our goal in general is to maximize function and promote independence. So I get the good fortune of working with a physical therapy department, and in particular Reenee, who pretty much tells me what I need to do, when, and I'm not allowed to proceed unless she tells me it's okay, which is fine with me if I agree with her. But we have a very strong multidisciplinary tactic, and I'm even sending patients to an osteopathic doctor who does manipulation, and I don't know what that is, but it is amazing. Physical therapy should start very soon, and it doesn't mean you need to be a skilled therapist. You don't need to go to school. You need to learn some techniques so that you can start from the very beginning. Anything touching and moving and getting those joints to go is a good thing for me. Not every child will walk, but most will. And we try to really encourage ambulation when we can. The first day that they come to me, Reenee's already asked me, how are they going to be independent at college? How are they going to live on their own, even if they're 2 weeks old? I've got to have that in my think tank on how am I going to get them to the final outcome. We do a lot of serial castings. We are very curious and courageous with our bracing, and we are lucky to have a fabulous gait So foot deformities are super common. Clubfoot is more common than vertical talus, but both are very apparent. It used to be the teaching that casting doesn't work for club feet. They're much more resistant. I don't disagree, but I would say that you can have really great outcomes with casting. Knee deformities and arthrogryposis. The most common is a flexion deformity. There is definitely a varying severity, and I think that these knee contractions are the bane of my existence. I don't think we have the full story yet on what to do. I'm telling you that honestly. Do you do surgery early like they do in the elbow? Do I wait? Do I do just casting? It's a tough question, and every child is not the same. Extension contractures are also around. They're less common, but definitely a difficult problem to work through. They may even be associated with a knee dislocation. Hip deformities can go right together with those knee deformities. So maybe later in their development, we can shorten the leg a little bit and decrease the forces. But the varying degrees of severity make this job very tough. I see a lot of unilateral and bilateral hip dislocations. In our practice at Nemours, we generally think that the hip should be in the socket, even in the bilateral group. I will tell you that it is not an easy hip to put back in. You have to be very, very careful. And sometimes you do get some complications, but there are some patients, which I'm going to bring up one very soon, that we didn't put the hip back in right away because she presented a little bit later. So you have to judge each patient on an individual basis. And I wish I had a textbook answer for every single one of you, but I do not. The spine deformities, this also affects about 28 to 67% of patients. It's usually a long, gentle curve, but it can rapidly progress. So sometimes I have to remind myself, don't just concentrate on those feet and knees and hips, you need to look above. So you can help your doctors look above and make sure they don't lose sight of that. Age matters when you're taking care of AMCers. Then there are different age groups that I will maybe prescribe something different in my either casting or surgical regimen. In the newborn, it's really a time for significant growth and time to capitalize on the opportunities for gaining flexibility. The tissues are different, they're much stretchier, and they hopefully will maintain some of the stretch. We're talking about tissues that are different though, and so they may not maintain all of it, and there could be relapses. That's okay. If a child ends up in the NICU at birth, that's all right too. I'm not going to cast you in the NICU, but I'm going to encourage the physical therapist, the occupational therapist to come in and visit and change the splints often. And more importantly, I don't want those hips to be stuck, squished together, because that's really a bad position for any child's hips, whether they're arthropodic or not. As an infant, we start talking about casting. Now, she's putting on a pretty fake smile here because this child did not like all this casting, I'm not gonna lie. But you know what, she tolerated it, she looks really good now, she's doing amazing things. We do a lot of casting, but I think, the magic bullet. I have Reenee, my physical therapist, doing her session of physical therapy right before my casting. I feel like that gets me like a double instead of a single or maybe a triple. And I don't like baseball, by the way. I do, like I said, I do address those subluxated hips, especially if the hip adductors are tight. As soon as I can, I really want the hips to be in, but if it doesn't seem like the right timing, I will wait. So talking about the success rate of casting in club feet, Merquenda worked with Dr. Ponsetti for about 20 years. He did a study looking at how successful are we with casting. He had a follow-up of about 5 years. This is Ponsetti's chair that he used to sit and tell Dr. Merquenda, no, no, no. 20 years into it, he still was saying, no, no, no. They had very good outcomes from this study. They achieved initial correction in about 90% of these club feet. And I would say that our numbers are very, very similar. I don't always have to use as many casts, but it seems to be a home run for me. So I'm an avid caster until I'm pretty much blue in the face, but sometimes you need to do a little intervention too. So I would say this is a pretty good outcome from a casting. This child was very contracted and his right hip was okay, not great. We casted and things turned around for him pretty well. he was able to stand. Now, I can't take the feet away from the knees and the hips, so just so you know, I'm looking at all of these at the same time and trying to get good alignment. And this is, once you get these feet in alignment, it doesn't mean the game is over. The game is just beginning. So here's another little guy, came to us at 2 weeks. I thought, oh my gosh, no way. The other thing I know from Reenee is that when I say no way, she says yes way, and she's always right. So we casted him, and again, we did a lot of stretching beforehand. His right hip was very flexed up, very complicated position I didn't think this was gonna work, but it did, and that right hip loosened up. I mean, this baby was very young, which was, I think, a huge, big reason why he came around so quickly. I don't put them into Ponseti braces for 23 hours. Typically with these guys, I actually try to do some splinting. This family comes from a distance. I'm very close to them now, but they come from a distance, so making new splints for them often is a little bit more difficult. In the hip and the knee, I really want to make sure that everybody is, people are learning to examine the hips with each casting, because things can change. Luckily, I have an ultrasound department that's right there, and I can usually call and send my child over for an ultrasound. They're tougher ultrasounds, so if you live in a place where they don't do many children's ultrasounds, they may have some trouble. Then I have to decide whether I'm going to brace those hips or I'm going to continue to stretch them. In the knees, I usually incorporate my casting with my clubfoot casting, and I'm very diligent to let the foot part totally dry and then concentrate on the knee as if it's a whole different procedure. That is really important because the plane of motion of those knees can be very tricky. So in the toddler age, we really emphasize the need for alignment and function. And the most important word here is play. Everything is about play. This is not a job. Remember, this is a journey to get them into these positions. Again, this is the child that the pediatrician said would never, ever walk, and he's never seen anything looks like this in his life. Well, good thing he looks just perfect now. This kid is an ATV rider with a helmet, thank God. He could ride a scooter earlier than my children without AMC. So, not to make Reenee feel too good about herself, but she really is my teammate, and we have much more success because we're together. She helps me assess the child for the current and potential modes of functionality. She really pushes my limits. She helps me get take this biomechanical approach. We get limb alignment, and then we try to put these children in their best mechanical advantage to maximize function. And that can be done with serial splinting, casting, therapy, stretching, all these things. It's a multi-modality effort that we make. All right, so our goal is comfortable bracing to keep the feet walking, running, jumping, and dancing. I work really hard to not take their childhood away with casting all the time. We really want them to be kids because that's what they were brought on this planet to be. So we try to make it fun. So how do we do if we really look at the data, looking at our serial casting with children with arthrogryposis? So we looked at some infants and older children, and we took some measurements to judge how we were doing. We looked at them in 3 time periods, pre-casting, short-term and long-term, and guess what? They did well. They improved their range of motion. There is recurrence, and recurrence is not a fail. It's just part of the process. We improved range of motion in infants, and this is all statistically significant. We improved them in older children too. So I'm okay casting a kid that's 10 years old. I don't have a problem with that, as long as somebody's doing therapy first. We improved their foot pressures. We improved their happiness, especially to their sports and physical function somewhat. So management in arthrogryposis, it's not a chip shot. It's definitely challenging. And you have to know when is something good enough. I will tell you, this child doesn't stop, but she has really tough feet. Those feet curl around, and despite my best effort, they really curl. I've done some small surgeries. She did fantastically with her upper extremity surgery. So we recast her because she's so young, just to get her into a comfortable brace. So I'm waiting on her as long as I can because I want that foot to grow long. So, but I'm going to tell you, she also doesn't have air under those shoes, and she's doing pretty well despite the fact that her feet, when I take those braces off, don't look beautiful. And there's a lot of sass that goes along with this. So anyway, look at the top right. You can't miss her. Oops. All right, so management of the arthropodic child that lives far away. What am I going to do? Because, you know, this treatment that I'm prescribing for some of these kids, it's going to change your family structure. It's going to change. It's going to be financially costly if you're traveling. You have to stay in a hotel. It's really taxing on both the family side, and sometimes just getting into my schedule is challenging. But you have to have a plan. You have to be able to work and be creative, and you just got to roll with it, because man, I can't believe that these feet turned around the way they did. So this is a really neat mold that they did of his feet before we did anything. And I'm going to tell you what we did, and I think I'll take it. So here he is, 2.5 weeks of casting with therapy. We did minor soft tissue surgery. I released the Achilles tendon. I released the plantar fascia. I think I might have done a toe flexor. They're two different feet. One's a congenital vertical talus. One is a club foot. And we send him home with 3 weeks of casting. He comes back. This is day 1. See, I told you, she's really good. Day 1, he's walking in a pillowcase there, because that's really a cool technique. And this is that maybe a half hour later, he's with the walker. Unbelievable to me. He's never walked in his whole life. So I'll take that. And that's why our hashtag is AMC Watch Me. All right, so then he gets home. So first he's still in our hospital. I think this is about 36 hours later. He's standing by himself, making some concoction that I could only know what it is. So I'm really excited about him. It does tell me that the power of casting and being persistent with these kids is worth it. All right, so Mary's sitting in the front, and so the other patient wanted to be my new Mary, because I always talk about Mary. So you can't just stop at the feet and the knees, even though I would say that it's pretty cool. A child that looks like the picture on the left has 4 casts and bilateral tenotomies, no other surgery. And she's a little older, so she did have some sedation. We have a day medicine, so that gives her some sedation to make the casting a little bit easier. And so you can't see her feet, but she's walking on her feet right there. So this is how she presented to my clinic. Pretty cute, but not walking like I would like her to walk. And her left hip is dislocated. And in the next, oh shoot. Can you make that video play for me? My AV person left. But anyway, she's walking pretty well in this picture on the right, and this is still with a dislocated hip. And this is 6 months after her hip surgery that she had an open reduction. I'm sorry you can't see the drama of her walking and then this, but I can't do that. And that is absolutely amazing to me. And it's beyond what I did, it's what they did. I take no credit for this. So that's phenomenal to me. And I pretty much show every human being alive that this girl is so cool. So as the children get a little bit older, we really need to time those surgical interventions to meet the family's needs. The family doesn't stop with my discussion in the clinic room. It goes much farther. Do we need to keep serial casting because they've just had another growth spurt? Do we need to rethink those braces because they just don't allow him to run and play like he wants to? And we also have to think long-term. Remember, she's already asked me how this kid's going to get around in college. So now I got to realize he's got to drive first, or she's got to drive first. And I'm going to say it 1,000 times today, relapses are common, and that's okay. We have to just manage them as they come. So here's this little girl that was hula hooping. She came to me at about 6. She's been wearing those braces, and anyone who has braces out here knows that a 3-year-old to a 6-year-old, there are a lot of brace changes in there, but these are still the ones from 3, and she can't walk. And she's already had major surgery, including them removing her talus. So there's not a lot of options for me. I could fuse the foot, I could put a frame on, I could do a lot of stuff, but I really don't want to do that because she's actually hula hooping and up on her feet and going to school and having a good time, and her upper extremity surgery went great, and she's bending her knee and she's standing on her feet, and I'm all happy about that. But I know I'm going to have to do something because that foot is not perfect, and it actually looks much worse than it does in that picture. But she's okay because the brace fits and it's comfortable. And every once in a while, just recently, we recasted her. So when we do deal with these relapses, we do the same thing. We start again. We do some physical therapy. We do some casting. I use a hybrid cast, so I use fiberglass and plaster together. I make them walking casts as soon as I can. With the older kids, it's usually immediately. And I try not to cast them for too many weeks. So remember, I'm trying just to get an acceptable foot that will take a brace. I'm trying to avoid multiple surgeries and trips to the OR. I just don't think that's good for any of us. So things to be aware of, though, in my casting protocol, I always warn people that sometimes you're a little sore when you come out of the cast. We jokingly call this a biologic osteotomy, that you get a little stress reaction and it may be sore. So one of the things that we can do is we can put a check strap on an AFO, which means that if you have a hinged AFO, you can actually make it turn it into a solid for as long as they need. I want to avoid surgery simply because I don't want those feet to be too short. If they're too short, they become a lever arm problem. So walking on that little stub is not, it's not the easiest. So every growth spurt is an opportunity to rethink the brace. We do make braces to match the feet. We don't stick with one kind. Again, everybody's a little bit different, so we need to modify our technique for that. But when do we stop waiting? Come on, I said I was a surgeon. I do like to do surgery. I like to do big surgery, actually. So when we can't tolerate the braces and our casting doesn't work, or they're really reaching skeletal maturity, and that idea that the foot's going to get too small is not as much of a problem. So as they get older, I would like to get the best alignment to allow them maximal function. So in my preoperative assessment, we have a lot of tools. I can do CTs, X-rays, MRIs, range of motion. I make sure my clinical exam is really good. I use gait lab analysis because sometimes the gait of a child with a stiff hip or stiff knee is really complicated, looking at the rotational profile and how it works in space, not just on a two-dimensional image. And a lot of times I'll actually make a 3D model of a foot or a leg or all of the above. So rule number one, if we're going to do surgery, you better wear cool socks. And luckily this day we were all wearing our coolest socks. So this is a 13-year-old. She has a very rigid foot. We had actually casted her for quite a while. Her other foot has turned out just fine. She didn't need surgery, but this foot wasn't giving anything up. So she really had gotten to the point where she had had enough, and I think she was old enough and skeletally mature. Oh, hold on. Sorry. See if I can get it to go. There we go. So you see she's walking on the outside of her foot, and there's really no ability for her to correct it. She's actually 2 centimeters short on that side. So in our pre-op assessment, we did some 3D modeling. I had a plastic model. I did some graphic design stuff to get this frame on her because I had to lengthen her and fix that foot at the same time. So this was a pretty complicated surgery, but lucky for both of us, it turned out okay. And boy, was this a labor of love. She stuck her tongue out at me before we even went back to the OR. So here she is sitting by her horses, annoyed because now I've got her into a boot. I won't let her ride yet, but I think she should be on her horse now. But she was anxiously awaiting, sitting out there, hanging out with her sisters while they rode. So as we deal with the late teens and early adults, we really are trying to assess what problems can we fix. I work at a children's hospital. There is an age cutoff. I usually can persuade them to stay later, thank gosh. But we do all the normal things. In every patient's room, I encourage healthy weight, healthy diet, healthy, doing exercise. Encourage their energy conservation. Do they have a wheelchair that works? Do we need to order one? Again, and I'm not going to lie, I don't usually get that question. She usually asks that question. So, but we also need to really push them to master their life skills. Can they lift their bottom to manage their clothing? Can they stand to transfer? Can they stand to toilet? Do they have the ability to stand in a kitchen and wash their hands or maybe cook something? Reenee always asks, what meal can you make for us tonight? I need to know that you have one meal in your back pocket. We also want them to stand and weight shift, because I will tell you, for all of us in the room, that our peak bone mass is made by about 25. So weight-bearing activities, even the typical children that are on the iPads and stuff all the time, please get them up, get them moving. It's really important for bone health. And then what can we do for exercise if your function and your mobility is not what everyone else is doing in the gym? All right, so here we go. The case. This is what I jokingly call the case of what are you thinking? So this is my really good friend. She's 16 years old. She's had some surgery on her back, maybe just a little bit. She has a 4-centimeter limb length discrepancy. Her knee was a little knock-kneed. Her feet were a little bit off. And I promised that I would disclose that this was her Halloween picture, and that you have to encourage, not discourage her. That she was so embarrassed that I used this picture. But she doesn't want to wear a lift anymore, and I totally understand that. But her left hip is dislocated. So what am I going to do? She doesn't feel like she's very tall, so she won't let me shorten the other leg. So I agreed to do something crazy. We straightened her leg out a few years ago, so it wasn't knocked anymore. It was still a little bit afterwards because she has some rotational malalignment, which we fixed mostly, but the hip is not in the socket. And so what we did was we actually lengthened this leg. I used an internal lengthening device. On this day, I will tell you, was the craziest day of my surgical life, because I was shortening a 5'3" child by the same amount that I was going to lengthen her, and it should have been the opposite. But she did amazingly well, and I will tell you that she looks pretty stinking happy, and we love her, and she's so beautiful, and she had in her life, she's had more than this, but in my life with her, we've done a little foot realignment, but nothing heroic, because she told me I wasn't allowed to. We fixed the rotation and the position of her knee, and we lengthened her. And I would tell you, she has one huge smile now, right? You're smiling right now. This is good. So in conclusion, here are some of the most amazing kids I know. The top picture doesn't show how contracted this child was. This is the one that I will tell you, Reenee really said. He came to me at 3 or 4 months, and I was like, oh, we've lost the window. It's not fast enough. And she said, just give it time. You will get him around. He's never going to walk, Reenee. No way, no way, no way. And darn if he didn't do it. Now, I have actually taken him back to surgery because he is pretty malaligned, and it's beginning to impact his walking. So he's probably the earliest one I've realigned and shortened, but I think that the shortening will make a big difference in his range of motion of his knee. So wait for it. Here we go. So this is my life. Watch me. And it's really watch your kids. And it's an honor to take care of them. And thank you so much for inviting me to this amazing talk. And if anyone has any questions, I absolutely feel free. Don't make it hard. Oh, you can ask me. Hold on 1 second. Does anyone have any? Or you can come up to me later, or I can't answer that question.
Does it happen sometimes?
Yeah, and some don't. It doesn't work. Yeah, come in. Absolutely. And
We are coming with a microphone for that question. I see that hand.
one of the questions that she was just asking me was, there are not every child will walk, number one. Not every child will function well with the legs that they have. So there is the option for some people do choose amputation. It's kind of interesting because I do a lot of congenital limb deformity. And most of the time when you're lengthening for long amounts, most people, I have to give both sides of the story. Do we want to do limb salvage or do we want to do limb reduction? And so there's so many details that go into this, and there's not one size fits all. And there are, places that don't see a lot of arthroposes. I mean, the pediatrician, I'm, in the Wilmington, Philly, that they came to see me near to Philly. Philadelphia has a lot of orthopedic surgeons, but not a lot of people know AMC. And I'm going to tell you that a lot of us see a lot of AMC, but do you know AMC? I would say no. I would say there's a lot more discovery. There's, I think the whole genetics world, we now have a geneticist in our clinic, and I think that's going to be a game changer. I think once we get down to that level, how can I best give you good outcomes? I'm trying my best. I think we're all trying our best, and sometimes we might have a difference of philosophy. That's okay. I don't think we have, that's the same truth as in almost all surgery. Thank you. So, I can walk if you.
I have a mic. So my question is mainly about my son's toes. So he's in AFOs, and his big toe really has started to curl out, I guess more inward, and it's causing rubbage here, and we don't really know what to do. And the orthotist that made his last set of braces said the only thing we really could do is kinesiotaping, but I cannot get it to stay on. But it's causing skin issues, so I don't know where to go with that. And he had a rare form of clubbed foot. He had concavous clubbed foot, so his are easier to manage, but still, his big toe is now starting to cause an issue with skin.
So if you've ever seen a clubfoot model in any of your orthopedics office, and I do prenatal conferences and I show them, and the one problem with the model is the toes are on it. And see, she's really gonna have a big head. So the toes are the bane of our existence, and it is true. They are very hard to manage. I do think kinesiotape is great. I think that trying to put something in between is a good thing, continuing to stretch them and not ignoring them.
We tried to do where you had the little insert, and I can't remember the reason it
She's
wasn't
really
going to work
smart
out.
sitting next to you.
Yes.
Let
So
me
you're gonna
do
see how dumb I am in a
reunification
minute.
on your brace. Let me do a reunification. Sometimes if you do a pad under the, oh, good. Okay.
So she does
Okay.
reunifications in
Oh,
my
yeah.
office and takes
It's
the
a
orthotist
modification
who's
made
right
by
across the
Reenee.
hall and fixes the braces. Anyone else?
That's my big question.
I got you. Oh, she's got her running pants on, much better than my heels. Thank you.
So my daughter had one hip closed reduction, the other open reduction. So with the closed, it's still not exactly where it should be.
How old is
And
she now?
She's 14 now.
Okay.
So at the time, we opted not to do anything because we didn't want to set her back, and I wanted her to be able to make that decision.
That's probably an awesome decision for her.
Okay.
So
I couldn't do it.
it's fine.
And we've seen multiple physicians, and one of the reasons to do it at the time was because she was active. And that the theory being because she was probably going to continue to be active throughout her life, it could cause a problem. Can you debunk that or confirm?
So, it's not the same with developmental dysplasia of the hip, but there are some times that you have sort of a subluxation. And now that she's 14, the surgery is a little bit more involved. One of the reasons why you would say if she's not loading the hip all the time, it probably won't lead to being as painful, but it's still not in the right spot. So if you're going to do something like that, most likely you're going to end up doing something to the thigh bone and to the acetabulum. And you just need to be with somebody that does that all the time. You want someone who does high numbers. So I have a hip specialist in my hospital, and I will tell you, I like doing the hips. I won't give them up, but I always do them with him because he sees all different kinds of hips, and I always get the hard ones. So he's like, oh, you're bringing that one to me? But you want someone who really appreciates the fact that one hip is not this, like an arthrogrypotic hip is different than a lot of other ones. And you're trying to prevent a hip replacement. So if it's painful, then you may want to just keep reaching out and see who you're most comfortable with. And I think the relationship with your doctor and your therapist is monumental. And just because Jane went to see Dr. So-and-so doesn't mean that you can't go see Dr. So-and-so. Sure, get as much information as you can, make sure their numbers are high. But if you just plain like them a lot and you think they're very caring and compassionate, They have good, most of us have long-term training, but this is hard stuff. And the surgical outcomes it's not always 100% predictable, but you want a hip specialist if you're going to go down that route. That would be my best.
Currently, she doesn't have any problems or pain.
Just
so-
to start teasing out who around your neighborhood, because closer is better, right? But if you can find somebody that's really, really good with that, I think that makes all the difference in the world. And you can still, unfortunately, have complications even in the best hands.
I understand.
That's the thing that stings for me.
Thank you.
Hey, so going on the hips still, I have a 4-year-old, almost 4-year-old, who is kind of where they were. She had an open reduction on one side and a closed on the other side. And it wasn't fully successful. And so now we're talking about doing like a DEGA and a Salter osteotomy.
Probably a DEGA at this point at 4.
Okay, yeah.
And you may have to address, unfortunately, you may have to address the femur too, and
Right.
to tip it down. But a lot of times, is the knee contracted?
No, but the question is, so she's semi-ambulatory with a walker and taking steps independently. So we're trying to.
So that's where the timing comes in, right?
Right. What questions do you ask when you're saying, do we do this right now or do we wait? Because we've heard both sides and we want to consider everything.
Well, I'm really glad I waited on this little one here because it gave her the chance to really take off and walk. I think once you do turn those hips in a different direction, you may lose the ability to maximize the use of those particular muscles. Yes, Mary. Yeah, sure, come on up. So Mary needs to come up. But I think if you feel like you're about to hit a milestone, I would wait a little bit. I mean, I'm not looking at your x-rays, I'm just telling you my gut. And if Reenee agrees with me, then it's right. Hi, Mary. So this is Mary. She's like the most famous one, right? No, seriously, she like really does make me proud. She really makes me proud. And she's always really funny and she likes to see Dr. Thacker, right? Do you have a crush on Dr. Thacker? He's my hip partner. But again, you ask the right questions. What's the harm in waiting a little bit? Can we work on physical therapy? Can we do a little bit more to strengthen our hip? Do you want to say hi to everyone?
Yeah. Hi.
Yeah, there you go. Where do you live?
I live at my house.
You live at your house? You live in Virginia?
Yeah.
In Virginia. She doesn't have to drive all the way up to see me today. I get to see her, right? So exciting. She likes stickers too, just so you know, right? I hope that helps. It's not a slam dunk, but talk to that lady right there, and she can maybe give you some hip strengthening stuff that is fun. You just have to make it fun, 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 fun. Any other questions that I can address? Good job.
Since I'm here, my daughter's 15 and she's had the 8 plate put in her knee, and we've gone really good with that. But now they put it in her ankle, and it's to help her start being flat on the ground because she's still walking on her tippy toes and she's hurting. She has a leg brace. They built a heel in, but the doctor said, like, this is it. And my daughter's 15, she's coming in. She's mostly talking the whole time now and learning more. And the doctor was like, this is it. And Kendra got very disappointed because she's hurting. And I don't think we could do an Achilles cut again. And she's older and it's very stiff. So what would you recommend?
So is the screw on the inside of the ankle or through the heel?
Inside of the ankle. And he
Okay.
ended up putting 1 on one foot and 2 on the other. And it has been we see her getting closer to the ground. But then it hasn't really done anything. And we know she has one leg longer than the other because she's had amniotic bandings. So we were wondering why her back was hurting. I thought it was her back, her hips, and it ended up being one leg's longer than the other because of the amniotic. There's no blood flow. So she's just really hurting with her ankles, and I would love to be able for her to be flat.
At 15, I would be surprised if she has much growth plate left.
Right.
So it's not really doing anything right now.
Right.
Is the hardware bothering her, do you think?
No, it's not the hardware. But when that was our option, that was our thing about the growth plate and certain things that we could do now, or do we wait because she is very short? She's hoping she gets, a couple more inches, and we don't know what's the next step.
At 15, the reality is that it would be very unusual for her to get a ton more growth, especially if she's postmenarchal. I would dispel that myth that she's going to suddenly shoot up. Now, things are possible, but I would have to see an x-ray to see what her growth plates look like.
Okay.
But the other thing, and I know there's a lot of controversy, but I'm a very big proponent of vitamin D supplementation. I really, on almost every single patient, I recommend at least 1,000 to 2,000.
Okay.
We talk ad nauseum about good health, avoiding sodas, because those things, when you're osteopenic, especially if she's not walking a ton,
she's
it is
walking
painful.
a lot. She's no more wheelchair. She's, going to she's in high school, so she has no aid. She's walking around to all her classes. She's doing really well. That's the next step is with her ankles.
And does she wear anything in her shoes?
She wears just her leg braces and then shoes.
1 second.
She's just still on her tippy toes and has the heels very much. We worked so hard to straighten out her leg, and then it was still, we
Tight.
corrected the foot, and then it was on her tippy toes still.
So a lot of times that the capsule, it's not just the Achilles that's tight. There can be some deformity through the midfoot. It can be through the distal tibia.
Okay.
There are a lot of places to make her tight.
Yes.
And there are ways to get her foot flat. Another option is to bring her foot to the ground to her foot instead of trying to force her foot to the ground. If it's just a little limb length or just a little bit of equinus contracture, you could probably offload that foot a little bit. This is where I turn to usually, unless you are looking at surgery, that I would turn to doing, is there something else that we can do? Can we make the cushion better for her? Can we
yes, definitely.
improve her nutritional status? Can we try that vitamin D for a few weeks or get a level tested and see how low it is?
She gets she picks out her own little packets, and I know we have that in there, but I will definitely
just
touch
check
base
it,
with
because
you as well.
sometimes bones don't heal and they're getting microfractures, and it is super painful.
Yes.
And it's a silly thing. If you can give some gummies, fantastic. It may not be the only answer to bone health, but it's certainly a good start.
It will help. It will help. Thank you so much.
You're
I
welcome.
can't wait for you to see her.
All right, you guys. Oh, sorry. One more. Yeah.
Hi. So our daughter Alexandra is 18, classic AMC. She has now, this lady just reminded me of a question. Alex has probably about an inch to maybe an inch and a quarter difference in the length of her two legs. She's had an osteotomy on one side. On the other, she's had a little more contracture over time, I think, in her right leg. So she has a bit of an imbalance in her walk. And we have been having that addressed primarily through building up the shoes on the right side. She's all of 100 pounds and 5 feet tall, and really proud of breaking that 5 foot limit. So she doesn't want to give up any of that. We've been kind of leaning towards encouraging her on an osteotomy on the right leg, but she's really quite reluctant to do that at this point. So wanted to just get your thinking on at that age, at 18 years old. And my concern long-term is she started to have some back pain, lower back pain. And because of the difference in the gait, I'm concerned about the pressure that puts on her hips or lower back. And so what would your thoughts be at this point with regard to an osteotomy?
The first important thing is that in our teaching, and it was sort of a dictum that was passed out that below 2.5 centimeters, you fix the shoe. Between 2.5 and 5, you shorten the other leg, not at 18, but at 12. And then, after that, you can consider lengthening. But I will tell you, if you take off your shoe and you just have your shoe and your sock, you have your shoe and sock on one side and just your sock on the other, you're going to notice a big difference. Now, that's been her life most of the time. The back pain part is because her back gets a little stiffer as she ages, number one. And number two, the back pain should go away if you equalize the hips. If it doesn't go away, then that suggests that maybe it's not just related to the limb length discrepancy. So for an 18-year-old with arthrogryposis, and they have a small limb length discrepancy, you have two options. At 18, you can either shorten the longer leg or lengthen the short leg, or do nothing and fix the shoe. And at 18, you don't have much say in that. So she just needs to be educated on what, when I did the "you're crazy doing this surgery" thing, I was terrified. But I had already done one that was even more terrifying, so I felt a little bit better. And I knew that this is what she wanted. And so her hip is already out. I can't dislocate her hip. But limb lengthening is not, it's not for the first time goers. Like you need to know what you're doing, especially in a person that doesn't have normal tissue. So, and it's not easy. You can talk to, maybe Gabby's sitting right here. So maybe you can talk to them about it. But it's not, a short lengthening, okay. I would tell you out of a textbook, or if you went to a million doctors, two of us would say, okay, I'll lengthen that for you.
Thank you very much.
You're welcome. Mary wants to say goodbye. Want to say?
Bye.
Good job, Mary. Thanks again.
Just checking to make sure they're both up and ready. Is it a pink cased cell phone? That's my cell phone. Yep, I think so. I'll come to you in a second.
So for those of you on YouTube, we'll get started in just a few moments. We are live in the room. We're just waiting for our speaker to join us, and we'll get started here in just a few moments.
Here, Mo, do you need? And then when you're done. Yeah. All right, so she's good. Should be ready to go. Yeah, and then after that, I'll just. And then the only thing we have to do is at like 3:45, we gotta push them because they're gonna start stripping everything. Do you need anything? I'm good. Okay. She should be back way in. Yeah, well, I'm almost gonna talk to her after. I know. Because they did. You're professional, yes, yes, yes. And so, do you want to be at the podium? I think I do. Okay, then you're fine. The mic's there, you're good.
If everybody can make their way in, we'd like to get Reenee started on time. Thank you for being here, and thank you to Reenee Donohoe for honoring us with her presence once again. She's awesome, we love her, and I know most of you do too. Thank you.
You know what, you need this for questions. Oh. Yeah, I guess, although it probably needs to be turned off. Yeah, I turned it off. Okay, cool. Hi, how are you guys? Thank you for having me today. This is a stretch talk for me because I have to tell you, I'm a physical therapist, and really what I do is physical therapy. I have this passion for arthrogryposis, but in the grand scheme of things, research is really a stretch for me. But I think that it's important. And let's see if I can figure out the... Oh, there. So what I want to talk about is I want to teach you about the difference between retrospective reviews and prospective research. I want you to figure out know why there's roadblocks to getting research done. You know, if you have a diagnosis that has a pharmaceutical company that wants to give you money to do the research, you can get research done easily because there's money, and research is expensive. And understanding the research of getting the troubles of getting research published about arthrogryposis also. So you say there's not a lot of research about arthrogryposis, but in all reality, there really is a bunch. It just doesn't really touch on it. If you did a quick PubMed search for the past 10 years in arthrogryposis, you'd find 670 articles that were related to arthrogryposis involving humans. But only 24 talked about ambulation, and only 18 included things that looked at activities of daily living. So there's research out there, but it's not functional research. And, you know, to me, function is the holy grail of life. You have to be able to be independent, and we need to be thinking about what that function looks like. Much of the research is related to genetics, which is great because they're finding out more and more about the genetic problems and genetic relations of arthrogryposis, which in some cases may find cures. A nice, interesting thing that when they looked at genetics and Escobar syndrome, they found that some of the kids that had Escobar had the same gene mutation as those with myasthenia gravis. And they were able to treat it effectively because they had a drug for myasthenia gravis, so it would make them stronger. So as they find more genetic basis for the arthrogryposis syndromes, they'll be able to find more connections and more treatments. So I'm not shortchanging the genetic aspects, but I do think that when you're looking at arthrogryposis, there's a huge bias towards can you walk? And there's not, and when they look at function. And to me, I think walking is icing on the cake. And there's plenty of great cakes that don't have icing, that are full of life and can make you really happy. So you really need to be looking at function at different levels also. So my husband is a researcher. He's a college professor, and I told him I was going to talk about IRBs, and he's like, why are you bothering to talk about that? But, you know, there's so many hoops that you need to jump through in order to get research done. And, you know, researchers have to go through hours of training in order to get that to happen. And they have to get protocols through the Institution Review Board. And each hospital and university has an Institution Review Board. So if you're going to use multiple research venues, such as if Nemours was supposed to communicate with Shriners and with the University of Delaware, we would have to go through 3 IRB processes to do multi-center research. But they all have their own stipulations, and it takes a while. So what does it do? The IRB protects the welfare of the individuals that are being researched. And they approve and disapprove, and they change what happens within the research protocols to make sure it meets their standards. And there's a bunch of people on the IRB board that give the IRB diversity to make sure that they're not just all orthopedic surgeons that are looking at an orthopedic problem, but that we're looking at people not just one flavor, but multi-flavored. So you can get consultants involved, and they keep track of FDA approvals, and they keep track of ethical issues and keep us on target. And I tell you this because when we do IRB approvals, we have to get that team together, and the team meets about monthly, and then they'll give you feedback as to what happens, and then you have to get it in before the next meeting, which will be monthly, and it can take up to 6 or 7 months to just get that idea of a protocol into approval to be able to start something. And so it can be quite hard to get research started, especially if you're somebody like me, where I carry a full caseload of patients, and I do this as my extracurricular activity. So research can be really expensive to run, and it can be hard to run, and so it requires time, and if you have professionals that are working at an institution, their time has to be paid for, and you need time to write the protocols, and you have to do the researching, and you have to have meetings with the people that you're participating with, and you have to do data collection, and you have to analyze the data, and you have to write the results. It takes time, and data collection takes time, and it's paying for the statistician, and if you're going to have somebody, if you're going to do a large study where you're bringing people together to do it, you have to pay people to help you collect your data. Sometimes if you're traveling to a place to do your research, you have to pay for space. Sometimes you have to pay for travel and for all of the people that are traveling to do data collection, or you have to pay for travel to present the data, because research isn't research unless you share your data and make sure that it gets out there. So it can be very expensive. Okay, I got all through the IRB and the protocol stuff. So let's talk about 2 different types of research. There's 2 different types of research, basically, and I'm really going basic, guys, because I'm pretty basic. There's retrospective reviews and there's prospective reviews. Many of the people with arthrogryposis have been involved in retrospective reviews, and they have no clue that they've been, because retrospective reviews are able to report on outcomes, and they can make assumptions based on experiences, and they're really based on chart reviews and data review that has been collected in the past, and then we kind of group it together. And we get the IRB to approve to do this, but we don't have to go individually to each person that we're looking at their chart, because we're not trying to change anything or do anything that new to what has happened. So I wanted to share some of the things that I have done in my free time. This past year, I got this paper published in JPO, and it looked at body types with amyoplasia. And this was a labor of love that took a really long time, took longer than it really had to, because I had no time to be able to get it written. But what we did was we categorized kids with amyoplasia that we saw into 5 groups. And we were able to figure out what they did, what they looked like as babies and what they did at maturity. Because if you look at my gray hair, when I started working at DuPont, I had really nice brown hair and I was young. And now I have really nice gray hair and I'm not quite as young as I used to be. And nor are my babies. So we separated them out. Type 1 have mild ambulatory impairment. They're the kids that come out. They might have club feet. They might have a little bit of contracture in their legs. But overall, they kick them out. They do great. We fix their feet. They walk on into history. And we really don't follow them that closely because they're doing so great. The second impairment type is the mild impairment, the moderate impairment. And they look very much like the severe impairment. And I'll get into that a little more closely because there's distinct differences. And then the mild ambulatory type are the jackknife kids that they're born with their feet up over their heads. They often have stiff knees and they often will have subluxed tips. But these kids are rock stars. They do crazy, amazing things. And then there's the variable ambulatory type where one leg is straight and one leg is bent. And so they come out and they have one hip that's subluxed and one that's not, and they're uneven in their strength. And they're really uneven in how we predict. So let's look at birth presentation. So this is a type 1. And in all reality, it gives you the breakdown of what they look like and how they had club feet, but overall, they walk into adulthood without any problems. Type 2s, now at birth, these kids have really tight hip flexors and knee flexors, but most remarkably, when you touch, feel, and they kick, you can feel hip abductors and external rotators, and they fire and they pull themselves into more external rotation. I look at that child and I say to the parent, your child's going to walk with long leg braces into adulthood. And they say, well, how do you know that? And it's because I know that if we stretch them out and get them in the right alignment, they'll be able to use that muscle strength in order to walk into adulthood, as long as they keep on top of their contractures for the most part. And we have had, and they end up having some surgeries, and they end up needing to wear long leg braces to walk, but these are the kids that tend to walk. Now, this baby looks quite similar to the one in the slide before, don't you think? The difference is that child has jello for buns. When they cry, their hips flex, their hips flex, their hips flex. Nothing kicks backwards, nothing kicks outwards. It's just hip flexion, and they tend to bend their knees more. Now, remarkably, we can get this child up and standing. We can get this child up and walking. And in the first decade, they do walk. The challenge is when they get older and it's harder to walk, they tend to fall into a chair because it's really not energy efficient to try to walk with the weakness that they have at their hips. And it's really stressful on their low backs. So the type 3s have severe ambulatory problems. And then the type 4s, most of them have bilateral dislocated hips, but not all. Some are born looking like that, and magically their hips are in. And none of them have developed scoliosis, which was very interesting to me, because scoliosis, if you have been watching, everybody has had a few. But in this population, none of them developed scoliosis. And we've done some osteotomies to derotate them because their knees tend to be externally rotated along with their stiffness. And some of them have patellar tracking issues that we need to do. But these are the kids that walk and do crazy, amazing things. Now, the type 5s, they're very uneven. And so they have one hip in, one hip out, one straight, one not. They have a huge tendency towards scoliosis. If you have a child that comes out looking like that, you have to put the dislocated hip in. I'm not big fan of surgery. I try to avoid surgery more than anything on the planet. And I really am not a huge fan of hip surgery, although my friends are. And so we dance around that a lot. But when you come out looking like that, one hip flexed, one hip straight, the straight hip is the one that's dislocated, you have to put it in because they're the kids that are going to develop scoliosis based on that asymmetry. And we have research to support it. But these are the kids that we can't tell who's going to be a really good walker and who's going to be not a walker at birth, because they have very asymmetrical strength that goes with their very asymmetrical alignment. And if they develop a huge scoliosis that is the asymmetry that comes up the line, they become less able to walk. Or if they get really heavy, they become less able to walk. So if you just look at, I don't know if there's you just look at this, type 1s, they all walk. Type 4s, most of them walk. Type 3s, none of them walk. We can really predict that. We have a third, and a third, basically, for the type 2s that walk. And if you look at these together, we have more that walk than don't walk into adulthood. And then the variables, they really are variable. Does that make sense? So alignment at birth influences what they're going to do in adulthood, basically. And strength really impacts on what they do. And all of our kids walked in the first decade of life. They might have needed bracing above the waist. They might have needed a lot of bracing. It might have been really hard. But everybody took steps independently at some point. Who kept that ambulation status really depended on where their strength was. So let's talk about the research that started, but it's not finished. Because remember, you can collect the data, and sometimes you can collect the data and you don't have time to get it written up. And sometimes you get it written up enough to put a poster together or put a presentation together in a room. But if it doesn't hit a journal where the world can read it, it's kind of like a tree falling in the woods. Because the people in the room can hear it, but did it get heard anyplace else? So this is a very busy slide. And what we were looking at is foot deformity and kids with arthrogryposis. And our conclusions were, it's really nice. We send all our kids that we're doing clubfoot relapse work on to the gait lab so we can get data as to what they look like when they started and what they look like after we did casting. And so we get foot pressures on them to track change. We have figured out that the gait analysis works for this population, that the foot pressures work. We have figured out that they tend to weight bear more through their forefoot, like you didn't know that already. We found that they tend to have less power, like you didn't know that already. We found that they're stiff, like you didn't know that already, and that they tend to be more flexed than extended. And I'm telling you things that we all know, but unless you've done the research and you publish it, it's like it never happened. And so you can say, I know this, but unless it's published, it didn't happen. And here, another one that we're doing is, I am all about prediction. I'm all about, I see a baby in the clinic and I want to be able to say, this is what they do in the future, because I want the future to be as functional as possible. And I want families to be prepared for what the future holds for them. And if I'm wrong when it comes to me saying that they're not going to be the best walker on the planet, I am happy as a clam, and because I want to be wrong on that. But if I prepare you for what you need, that's great. And so we know that 61% of our kids over the age of 18 months could walk independently. I always tell families by 2 years of age, you're going to walk. And I think that that's really a good go-to idea. But down the road, they don't stay on their feet. So we sorted kids into groups. And last summer, we had a research student that went through all of my old charts. It was like the history of arthrogryposis done by Reenee. And she went through all of my old paper charts and sorted out my patients. And we grouped them into 6 categories initially, and then got it down to 4 because 4 is an easier number to use for research purposes. And the group 1 were the kids, just like the group 1, type 1s that we talked about before. They had great quad strength, they had great glute strength, and they walked with with AFOs or less. Group 2s were community walkers, but they used CAFOs and some used wheelchairs, and they had less than anti-gravity strength at their glutes. And then type 3 were limited community ambulators, and they had good upper extremities, so they could use an assistive device. And then group 4 were the ones that could just transfer. And it helped us predict a little bit. And what we found was that glutes and quads, as we have talked before, are really indicative of how well you walk into the future. The alignment of the hip and the knee help improve your outcomes for walking, and strengthening programs help improve your outcomes for walking. And more importantly, we need to find other functional measures than just walking, because not everybody walks, and we need to know what that looks like too. Okay, another study waiting for publication. Can you tell that we're busy, but we're not getting there yet? And I feel really bad about our retrospective reviews not quite getting there, but it's great. One of the things that Dr. Nichols and I have been doing for as long as Dr. Nichols has been in the building is I've been stretching those relapsed club feet for about 20 minutes per foot between each cast change or before a cast, in order to mobilize each individual joint and make sure that foot is doing what it's supposed to do at its best alignment before we throw the cast on. And we really thought that we were doing a good job, but we didn't have any proof that we were doing a good job. And so we started sending our kids to the gait lab so we could do that. And we use Ponseti hold for our casting, but we don't always adhere completely to Ponseti method, because Ponseti method likes to flex the knee and bring with the casting and really keep the kids in a knee flexion, full correction foot position. And it drives me crazy to get kids off their feet. I want them walking. So we tend to put anybody that's ambulatory that can possibly tolerate a cast over the age of 4 in a short leg cast and keep them walking. So we did some research on us. And so what we did was we found out, and Reid actually, if you were in last session, she presented part of this. We found that we had improved passive range of motion. Well, of course we knew that because our charts looked at that. Our foot pressures improved. And the gait lab does this test called the PODCI, the Pediatric Outcome Measure Index or something like that, I forget. But the PODCI is this tool that looks at happiness and function and things like that. And the parent-reported outcomes improved dramatically during that. And even though we know that there's a relapse of club feet without surgical intervention, we know that we can get them through a bunch of growing years before we need to do surgical intervention, because we know that we get good results because we did this. Okay, so now let's talk about prospective research. Prospective research is the stuff that happens here and now. What we really are not going to talk about today is the interventional prospective research. Those are like the drug studies or the retest, blinded studies that you hear about. We aren't there. We are going to talk about questionnaires. We're going to talk about testing without intervention so we can do data collection. We're going to talk about validation of tools. So this is where I go into never underestimate the power of an AMC mom. Because last July, I met Meg. She came to our clinic with her newborn, and she told me that she was a PT at the University of Delaware. And she had a newborn with AMC. And then we saw her daughter and did some casting, and I encountered her at the International Arthrogryposis medical meeting. And while we were there, there was a adult gentleman who stood up in the audience and said, "What are you doing about pain with arthrogryposis?" And while we sat there listening to him ask the question, you could have listened to crickets in the room because no one had an answer. And it was really unnerving, the fact that here we have the world-renowned professionals that have dedicated their lives to arthrogryposis, and the one nagging issue in adulthood in arthrogryposis is pain, and nobody has looked. And so we sat down at a breakout session, and at the end of the breakout session, Meg says to me, "We can do this." She said, "I've been doing this with the amputee population. I work with the amputee coalition. We can do this. We can go to the arthrogryposis meeting and we can collect data on individuals. And we can figure out what it looks like, and we can get data, and we can figure it out to help make a difference." So never underestimate the power of a mom. She is my party planner. I go in and I say, "This is what I want to do. Can you do this? We can do that." And she says, "No, Reenee, that's not real research. You have to do it this way. And let's bring it in." And she brings the reality of what it costs to be able to do research. And she brings it into how to do real research. And it's been a true growth experience for me because I'm a bit chaotic, to say the least. And so on the path of all of this, I also encountered a patient whose family does a run every year, and they have a New Year's Day run, and they said, "We'll give you our check this year." And so thankfully, they gave us this chunk of change that unfortunately we used really quickly because we rented space downstairs. So you too can be an active participant in the research process. We're doing a couple of studies through the University of Delaware and in conjunction with the Moores, and we're hoping to validate some balance tests on the arthrogryposis population, and we're looking at pain. And we hope to learn more about the arthrogryposis population in general. Who can participate? Well, if you're between the ages of 10 and 50 and you're not pregnant and you haven't had surgery in the past 6 months on your spine or your lower extremities. For those under 18, you need to bring a parent with you for the consents, and you have to be a willing volunteer. We cannot push you to do this. Why the age cutoff? Meg brought it to my attention, and this really upset me knowing this, but over 50, such as myself, you fall into the geriatric population. And since geriatrics like me can't participate in research if that touches the pediatric population, we can't have the geriatrics touch we have to do adults and peds. We can't do adults, peds, and geriatrics. It's too many variables. But we know that children with arthrogryposis tend not to have a lot of pain, and we know adults with arthrogryposis have pain. So we kind of need to figure out when that starts to happen and what it starts to look like. And the tighter age range gives us a better opportunity for publication. Why are we collecting data now? Well, where else do we see this age range in a large group? It gives us the opportunity to get as much as possible in a time-efficient manner. It gives you something to do. It gives you something to talk about. "Oh, I participated in Reenee's research. It was great. It was really easy. I feel like I did something." And you know what? You're going to make a difference in the arthrogryposis world because we're going to look at pain, walking skill, and fall risk, and your data will be important to our data, and you'll make a difference in creating a difference in arthrogryposis. So we have two studies. We have one that's an ambulatory study, and that's where we started. And I was like, Meg, we have to do something for the people that are in wheelchairs because not everybody walks, and I know that everybody has pain. So we can do the same surveys, but let's talk about the walking ones first. But trust me, it's not just about walking. The aim of the study is really to evaluate pain and function and to look at fall risk measures so we can have them validated for the arthrogryposis population. There are no functional measures that are validated for the arthrogryposis population at this time, which is huge because when they do research and they use functional measures, how do you know that it's measuring what it's supposed to be measuring if it's not validated to the population? So it's nice to use a tool, but it's even better if you can say that tool works for these people. And we're doing some retests to make sure that that tool works for these people. And so we like to administer the test between 12 hours apart, at least. So if you're going to test today, which if you haven't tested already, we would like you to test as soon as possible so we can test you again tomorrow. Oh, with the life study, we're just doing all of the questionnaires that we are doing with the age study. So we're not doing the validation of fall tools because when you're sitting in a wheelchair, you may fall out of your wheelchair, but it's not as common as it is to walk down the street and trip over something and go splat and not be able to get back up. But the pain component is really important. So we want to make sure that we take care of that. We have this great team that's with us. Meg Sion is my party planner. Tracy Shanks, she's presenting tomorrow afternoon, and she is an OT who is very invested in research, and she's really smart, and you should come to her session tomorrow. She's working with Ashley Pigford on adaptive devices. Harry Lowell is one of our orthotists, and one of the wonders of having, and Reid Nichols, you guys know, she's our orthopedic surgeon. One of the wonders of having all of these different areas of people that are involved makes it so we have different places we can put articles to get it out into journals. So we can put it in the OT journal, we can put it in the PT journal, we can put it in the orthopedics journal, we can put it in the prosthetics and orthotics journals. We can get it accepted to these sort of meetings because we have enough different players on the team that we can get the arthrogryposis word out and it makes sense. And then we have a bank of individuals that have come from the University of Delaware that are students that are just, they are not donating their time. Let's just put it that way. They are paid to help us out, and they are rock stars, and they're very invested in what we're invested in. So how much time will it take? Well, the age study, the first visit takes about 45 minutes by the time you fill out all the surveys and you do your walking test. The second time we just do the walking test, and that takes about 20 minutes. The better walkers go faster, the worse walkers go slower. The life study takes about 20 minutes, and we send a survey to you at home with you for you to send back in about 10 days. What will you do for this? What will we do with this? We'll collect data for this year and we'll report back next year, we promise. We have enough people collected at this point, we can report back next year. We'll use this to inform future research and find out what's important to you. And we'll use the data to help gain more funding for research that's important to you. In reality, without money, we can't make it happen. So we really have to have data collected that is publishable, that we can work on getting grants and we can work on getting funding, because we won't be able to do this year after year and get more and more information without the dollars. And this is just the team that I work with at Nemours, and I think they're great. And I would love to take questions from you guys at this point. There you are.
Away from,
Is it working?
yeah, I just want to get
Okay.
away from that. So in the original group you were talking about where you had patients, you had looked at their files. What are the age of the people who you looked at in the groups?
The kids that I grouped together?
Right.
So we looked at the oldest is 35, and the youngest was 18. So, and they were all kids that we saw before the age of 1 year of age. And most of them we saw in the NICU. I think only 3 of them I didn't have from birth. So it was a pretty clean group.
Thank you.
Anybody else?
Hi, I'm actually a physical therapist, and I had a question from before the doctor said you're using a pillowcase.
Yes.
To help the child walk, and I was wondering what exactly you did.
You know what? I use a pillowcase. I call it the magic pillowcase, and it really is just a safety net. I'll cut the corners of a pillowcase, and that child went from walking with the walker to the pillowcase because he started with holding on to the walker, and I was like, I think he can walk without holding on, but I didn't want to have my hands on him. I wanted to have him figure out step balance, and I wanted to see what he could do. So it was a nice way to make sure he didn't fall, but not have my hands directly on him.
All right, thank you. I work for the school system in Norfolk because we have limited funds right now for equipment, so that would be a cheap, easy.
You know what?
thing to
You
do.
can also use a big pair of shorts. But I kid that I've been at DuPont so long because I have to pay my laundry bill.
All right, thank you.
I was thinking about your slide. Oh, God, I just went blank. Oh, man. Give me a second. I'm sorry.
It's okay.
Is there someone else? Maybe I'll think of it.
It's okay.
I can't.
Okay. Anybody else? So Reid's here saying, don't just talk about the pillowcase, talk about the beach towel. So, sometimes I'll wrap a beach towel around if somebody doesn't need something behind them so much, and I'll just hold on to a beach towel. So that way they have something at their trunk, but I don't really have to have my hands on them. Oh, yeah, if they don't have trunk control, I'll wrap them in a beach towel so they have enough control to sit. But that's not what this talks about. Like make them a sausage. Yes. We are in the energy room on the 3rd floor. And how old is your daughter? You have to, a parent has to come with them to sign consent, and then she will sign assent that she agrees. And then we are collecting data until 6:30 tonight, and then we will be back tomorrow morning at 8 a.m. and go until 5. You got it.
I got it. Yes.
Nice job.
When you did your retrospective study of charts, how standard were the charts? Were you able to, did you have to throw out a lot of the data because
we had to
the standards weren't there?
I have to tell you, we went through 422 charts to get 66 kids. Because when I started working in PT, we didn't document like we do now. It wasn't anywhere near as clean. And so we really went through a lot of charts to get our sample that had all of the pieces of information.
Okay.
And remarkably, we had 422 individuals with arthrogryposis to go through that fit the basic criteria that they had gotten to age of maturity.
So do you think the results could have been different had the data been more standard?
I don't think so. I think we would have had the same 5 groups. I really do. Because it's really something I've seen over the years, and I can open up my crystal ball in the NICU and say, and no, unless the child shows up to have autism in adulthood, like when they're a little older, most kids fall into what I expected.
Okay, thanks.
Well, passing that way and then moving forward.
I just had a question on, I noticed that a lot of this research was on lower extremities. Is there any research on upper extremities? That
You know
you're aware
what?
of?
We will get there. I'm a physical therapist, and really my focus is from the waist down. I have always worked with amazing occupational therapists who take care of the upper body and really well. And I have gone through several over my lifetime at DuPont, and I tend to be the steady ender, so my data stays while their data does not. So Tracy would like to do something, and that's why we kind of dragged her along, because we want her to be looking at the population now to try to figure out where we're going to go for upper extremity measures. And we really are trying to figure out what the right tool is, because the population is so diverse. And we've done a better job of categorizing lower extremity and trying to figure out what the lower body looks like. We would like to do something similar in the upper body, and I know that Montreal Shriners is working on that. And I think that I don't want to steal their thunder because I have mutual respect. And so they may be presenting something at this meeting on how they're categorizing upper extremity. Let's see. You can pass the mic up the row this way.
So for the study that you're doing today, you said no spine or lower extremity surgeries in the past 6 months. That's nothing done, no matter how insignificant.
That is one of our exclusion criteria, yes. Anybody else? Oh. Which one? It is in the Journal of Journal of Pediatric Orthopedics, and it came out January, February. So yes. I don't know. I would not spend that money on my article. If you want it that bad, email me. No, you have to make a donation towards our research. But no, you email me if you can't find it, and I can find it in my bag today. Any other questions? Thank you. Thank you for coming. Thank you for listening. And thank you for thinking about being participants, even if you choose not to. But more importantly, if you choose not to, talk to somebody else and encourage them to participate. We hope to get 50 people this go round, and we're more than halfway there. So please go, please.